Riverside General Hospital falls into stunned silence as Mayo Clinic CEO Jonathan Pierce arrives with senior medical leadership, their presence commanding immediate attention while video evidence of Nurse Naomi's brilliant diagnosis plays on monitors throughout the packed conference room. Dr. Richard Hartman's confident medical authority crumbles as he recognizes the flaw. Nurse he'd dismissed 12 hours earlier, the same woman he'd told to stay in your lane and let doctors handle complex diagnoses. "Good afternoon, Dr. Hartman," CEO Pierce announces, his voice carrying unmistakable institutional authority throughout the assembled medical staff. "I'm Jonathan Pierce, CEO of Mayo Clinic. Some of you may not recognize Dr. Naomi Richardson without her surgical scrubs and chief credentials. The Mayo Clinic chief of surgery you dismissed as just a nurse who doesn't understand medicine." His eyes lock onto Hartman, who has gone pale. "Dr. Hartman, I believe we need to discuss why you ignored Dr. Richardson's correct diagnosis of dissecting aortic aneurysm, proceeded with your incorrect treatment plan for anxiety, and told nursing staff that nurses should focus on bedpans, not diagnostics." The gathered medical staff freeze in recognition. The physician who 12 hours ago had absolute diagnostic authority now faces the Mayo Clinic chief, whose expertise he dismissed, and medical board investigations are already underway. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed, because tomorrow I've saved something extra special for you. 8 weeks earlier, Dr. Naomi Richardson had been presiding over Mayo Clinic Department of Surgery leadership meeting when she made the decision that would temporarily transform her from one of the nation's most respected surgeons into anonymous floor nurse seeking to reconnect with the patient care that had once defined her calling. At 46, Naomi had built her medical career on diagnostic excellence and surgical innovation. Her appointment as Mayo Clinic Chief of Surgery, representing both personal achievement and recognition of her exceptional ability to identify complex conditions that other physicians missed. Her journey from inner-city community hospital to Harvard Medical School to Mayo Clinic leadership had been shaped by witnessing healthcare disparities and the critical importance of listening to patients and nursing staff whose observations often contained diagnostic clues that physicians overlooked. But the administrative demands of chief position had gradually distanced her from direct patient care, her days consumed by budget meetings, personnel decisions, and strategic planning rather than the bedside medicine that had inspired her medical career. "I became surgeon to save lives, not manage spreadsheets," Naomi had confided to her mentor, Dr. Solomon Mitchell, former Mayo chief whose guidance had shaped her career. "I miss patient interaction, the diagnostic challenges, the direct care that reminded me why medicine matters." Mitchell had suggested unconventional solution. Take sabbatical. Work as floor nurse somewhere nobody knows you're Mayo Clinic Chief of Surgery. Reconnect with bedside medicine. Remember your calling, then return to leadership. With renewed perspective, the idea had seemed radical, chief surgeon working as staff nurse, but Naomi's burnout and desire to escape administrative pressures made the anonymity appealing. Mayo Clinic leadership had supported the sabbatical. "Dr. Richardson needs time to recharge. Her contributions to this institution are invaluable, and we want her to return energized rather than burned out." Naomi had chosen Riverside General Hospital specifically because it was a struggling community facility where nobody would recognize Mayo Clinic chief, where she could work anonymously, providing direct patient care without the weight of her reputation and administrative responsibilities. Her credentials as Naomi Richardson, RN, were technically accurate. She had maintained nursing license throughout her medical career, though the application omitted her medical degree, surgical training, and chief position that would have made anonymous floor nursing impossible. Riverside General Hospital was exactly the challenging environment Naomi had sought. Understaffed, overwhelmed, serving primarily low-income patients, and struggling with the kind of resource limitations and systemic problems that administrative experience had taught her to recognize, but bedside nursing would help her understand from front-line perspective. Dr. Richard Hartman, Riverside's chief of surgery, ran the department with authoritarian style that prioritized physician hierarchy and dismissed input from nursing staff whose clinical observations he considered inferior to physician judgment. At 58, Hartman's medical philosophy reflected traditional physician-centered model, where doctors made decisions and nurses followed orders. His approach, creating hostile environment where nursing expertise was systematically undervalued and patient care suffered from inadequate interdisciplinary communication. The institutional culture at Riverside treated nurses as subordinate workers rather than essential clinical partners. Their assessments routinely dismissed by physicians who believed medical degrees conferred exclusive diagnostic authority. Head nurse Patricia Hayes had been documenting concerning patterns of physician dismissiveness affecting patient safety. Doctors ignore nursing observations about patient deterioration. We see patients throughout shifts and notice subtle changes physicians miss during brief rounds. But our concerns are dismissed as nursing anxiety rather than valuable clinical data. The systematic devaluation of nursing expertise had created an environment where preventable complications occurred because physician arrogance prevented effective team communication and collaborative care. Naomi's first 7 weeks as floor nurse had been revealing. She witnessed firsthand how physician hierarchy damaged patient care, how nursing observations were ignored, and how her diagnostic insights were dismissed because they came from just a nurse rather than physician with medical authority. But she had maintained her cover, biting her tongue when physicians made obvious diagnostic errors, deferring to medical authority even when her surgical expertise recognized problems doctors missed, and experiencing the systematic disrespect that nurses face daily from physicians who considered themselves superior. The patient case that would expose her identity and transform Riverside's medical culture was about to test whether Naomi could remain silent when physician dismissiveness threatened to kill patient whose condition she instantly recognized, but whose treatment required revealing the expertise she'd been carefully hiding. Nurse Naomi Richardson was completing evening rounds when Mr. Marcus Johnson arrived in emergency department via ambulance, his symptoms immediately triggering her surgical instincts, despite her current role as floor nurse rather than Mayo Clinic chief of surgery. Marcus, a 54-year-old construction worker, presented with severe chest pain, shortness of breath, and back pain that he described as tearing sensation radiating between shoulder blades. Classic presentation that Naomi's 20 years of cardiovascular surgery experience instantly recognized as potential aortic dissection requiring immediate intervention. "I've never felt anything like this," Marcus told the ER team with obvious distress. "The pain started suddenly while I was working, and it feels like something is ripping inside my chest." His description was textbook for aortic emergency. But attending physician Dr. Lawrence Hamilton was already forming different conclusion based on superficial assessment rather than thorough diagnostic evaluation. "Mr. Johnson, your symptoms suggest anxiety attack possibly related to work stress," Hamilton announced after brief examination. "Your vital signs show elevated heart rate and blood pressure consistent with panic disorder. We'll give you anti-anxiety medication and monitor you for a few hours." Naomi's medical expertise immediately recognized catastrophic misdiagnosis, dismissing aortic dissection as anxiety was error that would kill patient within hours if not corrected. Immediately, "Dr. Hamilton, I'm concerned about the patient's pain description," Naomi interjected carefully, trying to redirect without revealing her surgical expertise. "The tearing sensation and back pain radiation seem unusual for anxiety. Should we consider cardiac workup or imaging?" Her suggestion was appropriate nursing advocacy based on clinical observations, but Hamilton's response revealed systematic physician arrogance, dismissing nursing input. Nurse Richardson, I appreciate your concern, but I've examined the patient and determined appropriate diagnosis, Hamilton stated dismissively. Anxiety commonly presents with chest pain that patients describe dramatically. Anti-anxiety medication will resolve his symptoms. The patronizing tone, while ignoring obvious diagnostic red flags, demonstrated exactly the physician hierarchy that Naomi had witnessed throughout her weeks at Riverside. Dr. Hamilton, the patient's pain pattern and sudden onset really concern me, Naomi persisted, her surgical training making it impossible to remain silent despite her cover. Could we at least get chest X-ray or CT scan to rule out vascular emergency? Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. Her clinical reasoning was appropriate for any nurse. Though her specific knowledge about aortic dissection reflected expertise she was trying to conceal, Hamilton's irritation at nursing challenge was evident. Nurse Richardson, ordering unnecessary imaging wastes resources and time. I've made clinical judgment that anxiety is appropriate diagnosis. Please administer the prescribed anti-anxiety medication rather than second-guessing physician assessment. The direct order to stop advocating for patient safety demonstrated systematic failure where physician authority overrode clinical evidence and nursing expertise. Head nurse Patricia Hayes, observing the interaction, privately supported Naomi. You're right to be concerned. Hamilton frequently dismisses nursing observations, but his diagnostic accuracy isn't as good as his confidence suggests. Her validation confirmed that physician arrogance was a systematic problem affecting multiple patients. But hierarchical culture prevented nursing staff from effectively advocating against physician errors. Marcus's wife, Grace, arrived and described his symptoms with additional detail. He's never had anxiety. He's a construction foreman who works in high-stress situations daily without problems. This pain came out of nowhere while he was doing normal work. Her testimony contradicted anxiety diagnosis, but Hamilton dismissed family input as easily as he dismissed nursing concerns. Family members often don't recognize anxiety symptoms. Your husband will feel better once medication takes effect. Naomi watched Marcus's vital signs with growing alarm. His blood pressure was asymmetric between arms. Subtle finding that confirmed her suspicion of aortic dissection, but that Hamilton's cursory exam had missed. Dr. Hamilton, the patient's blood pressures are different in each arm, Naomi reported urgently. That's concerning finding that really needs investigation. Her observation was critical diagnostic clue that any competent physician should recognize as red flag. But Hamilton's response revealed dangerous combination of arrogance and inadequate knowledge. Nurse Richardson, blood pressure variations are common and don't indicate emergency, Hamilton replied impatiently. Please focus on administering prescribed medication, rather than creating unnecessary alarm about normal physiologic variations. His dismissal of textbook diagnostic sign demonstrated that his confidence exceeded his clinical knowledge, a dangerous combination that was about to kill patient unless Naomi violated her cover to save his life. The confrontation between nurse Naomi Richardson and Dr. Lawrence Hamilton escalated as Marcus Johnson's condition deteriorated, while the physician's arrogant dismissiveness prevented proper diagnosis and treatment of the aortic dissection that Naomi's surgical expertise had immediately identified. Dr. Hamilton, Mr. Johnson's pain is worsening despite the anti-anxiety medication, Naomi reported 30 minutes after initial assessment. Her clinical observations documenting progression that confirmed vascular emergency rather than psychological condition. Marcus was pale, diaphoretic, and his pain had intensified rather than improved with anxiolytic treatment. Progression incompatible with anxiety. diagnosis, but consistent with expanding aortic dissection that would soon rupture and cause immediate death. The medication needs time to work, Hamilton replied without examining the patient or reviewing updated vital signs. Anxiety takes longer to resolve than patients expect. His explanation ignored clinical evidence while demonstrating exactly the physician arrogance that prevented him from reconsidering obviously incorrect diagnosis. Naomi escalated her advocacy despite knowing it risked exposing her expertise. Dr. Hamilton, I really think we need imaging. The patient's asymmetric blood pressures, tearing chest pain, and deterioration despite treatment all suggest vascular emergency requiring immediate intervention. Her specific clinical reasoning reflected surgical knowledge that floor nurse shouldn't possess. But saving Marcus's life mattered more than maintaining her cover. Nurse Richardson, your persistent second-guessing of my medical judgment is inappropriate, Hamilton stated with obvious anger. I'm the physician and I determine diagnostic approach. Your role is implementing orders, not challenging medical decisions. The explicit assertion of hierarchical authority revealed systematic culture where nursing advocacy was treated as insubordination rather than essential patient safety. Mechanism. Head nurse Hayes attempted to support Naomi's concerns through proper channels. Dr. Hamilton, Nurse Richardson is an experienced clinician whose observations deserve consideration. Could we at least consult cardiology, given the patient's concerning symptoms? Her diplomatic intervention should have prompted physician reconsideration, but Hamilton interpreted nursing support as organizational challenge to his authority. Nurse Hayes, I don't require nursing staff to validate my diagnostic decisions, Hamilton responded defensively. If you can't support physician authority, perhaps you should reconsider your supervisory role. The implicit threat against Hayes demonstrated systematic retaliation against nurses who advocated for patient safety contrary to physician preferences. Mrs. Grace Johnson became increasingly alarmed as her husband's condition worsened. Something's really wrong. Marcus is getting worse, not better. Please, can't you do more tests to figure out what's happening? Her maternal instinct and clinical observations aligned with nursing assessment. But Hamilton dismissed family advocacy as easily as he dismissed nursing expertise. Mrs. Johnson, I understand your concern, but anxiety often appears to worsen before medication provides relief, Hamilton stated with false reassurance. Your husband will improve as treatment takes effect. His confident prediction contradicted obvious clinical deterioration while demonstrating how physician authority could override evidence from multiple sources, nursing assessment, family observations, and patient symptoms. Resident Dr. Brian Wallace quietly reviewed Marcus's case and recognized concerning patterns. Dr. Hamilton, the asymmetric blood pressures and pain pattern really do seem unusual for anxiety. Should we consider? Hamilton cut him off before he could complete the suggestion. Dr. Wallace, part of medical training is learning to trust your clinical judgment rather than ordering unnecessary tests for every patient. Complaint. The dismissal of residents' concerns revealed that Hamilton's arrogance affected not only nursing staff, but also junior physicians whose observations challenged his diagnostic authority. Naomi faced impossible choice: maintain, recover and watch patient die from preventable misdiagnosis, or reveal her expertise and save his life while exposing the secret sabbatical that Mayo Clinic leadership had approved. Dr. Hamilton, I need to tell you something, Naomi began, her decision made. I'm not just a floor nurse. I'm Dr. Naomi Richardson, Chief of Surgery at Mayo Clinic. I've performed over 500 aortic surgeries. Mr. Johnson has dissecting aortic aneurysm that will kill him in the next hour if we don't get immediate CT scan and prepare for emergency surgery. The revelation created stunned silence as medical staff processed that the nurse Hamilton had been dismissing was actually one of the nation's most respected cardiovascular surgeons whose diagnostic expertise far exceeded his own. While Naomi Richardson's confrontation with Dr. Hamilton unfolded at Riverside General Hospital, parallel developments at Mayo Clinic and within medical oversight systems were creating institutional response that would transform individual diagnostic conflict into comprehensive examination of physician hierarchy and nursing expertise. Devaluation. Mayo Clinic leadership had been monitoring Naomi's sabbatical through periodic check-ins, ensuring her well-being while respecting her need for anonymous clinical work away from administrative pressures. Dr. Richardson needed time reconnecting with direct patient care. CEO Jonathan Pierce had explained to board members concerned about extended absence of chief surgeon. Her contributions to Mayo Clinic are invaluable, and supporting her renewal serves our long-term institutional interests. But Pierce's administrative assistant had received concerning call from Riverside General's nurse manager about unusual situation involving nurse who demonstrated extraordinary clinical knowledge. We have floor nurse who seems to have physician-level expertise but claims only nursing credentials. Her diagnostic insights are remarkable, but attending physicians are dismissing her observations. The description had triggered Pierce's suspicion that Naomi's cover might be compromised, prompting immediate inquiry that would soon reveal she was involved in life-or-death confrontation. Meanwhile, medical quality oversight systems had been tracking concerning patterns at Riverside General Hospital, indicating systematic problems with diagnostic accuracy and nursing-physician communication. State Medical Board Commissioner William Park had documented multiple cases where Riverside physicians had made preventable diagnostic errors. Hospital shows pattern of missed diagnoses and inadequate interdisciplinary communication. Nursing. Staff observations are systematically dismissed, creating patient safety crisis. The institutional analysis suggested that individual case involving Naomi would reveal broader systematic problems requiring comprehensive intervention. Professional nursing organizations had been advocating for recognition of nursing clinical expertise and reforms addressing physician hierarchy. Nurses provide direct patient care throughout shifts and observe subtle changes physicians miss during brief rounds. Systematic dismissal of nursing expertise compromises patient safety. The advocacy framework was preparing institutional response to exactly the kind of physician arrogance that Naomi was experiencing at Riverside. Medical education reformers had been documenting how hierarchical medical culture damaged patient care. Physician-centered model that devalues nursing input creates environment where preventable complications occur because critical clinical information is ignored. The educational critique provided evidence base for reforms that individual cases like Naomi's could catalyze through demonstrating real-world consequences of systematic cultural problems. Dr. Solomon Mitchell, Naomi's mentor and former Mayo chief, had been in contact with her weekly during sabbatical. How's the floor nursing experience? Are you reconnecting with bedside medicine and remembering why you became physician? His mentorship had supported her sabbatical while providing outlet for frustrations about physician arrogance she was experiencing as nurse rather than recognized surgeon. Mayo Clinic Surgical Department had been managing without their chief, while recognizing that Naomi's absence created leadership gap. Dr. Richardson's expertise and judgment are irreplaceable. We're maintaining operations, but we need her back. The institutional recognition of her value would soon translate into active intervention when her cover was revealed and her diagnostic brilliance was demonstrated. Harvard Medical School, where Naomi had trained, maintained alumni network monitoring. Notable achievements. Our graduates are leading medical institutions nationwide. Dr. Richardson's work at Mayo represents exactly the clinical excellence we aim to produce. The professional network would amplify the story once it became public, elevating individual case to national conversation about medical hierarchy and expertise recognition. National Institutes of Health had been funding research on healthcare team communication and its impact on patient outcomes. Studies show that interdisciplinary communication improves diagnostic accuracy and patient safety, but hierarchical cultures prevent effective collaboration. The research validation would support reforms that Naomi's case would inspire by providing evidence that physician arrogance wasn't just a cultural problem, but measurable threat to patient safety. As Naomi revealed her identity to save Marcus Johnson's life, multiple institutional forces were positioned to transform individual dramatic moment into comprehensive examination of how medical hierarchy compromised patient care and how extraordinary diagnostic expertise could exist in unexpected roles. The convergence of Mayo Clinic institutional interest, medical quality oversight, nursing advocacy, and research evidence would ensure that Naomi's revelation catalyzed systematic reforms rather than remaining isolated dramatic incident that changed nothing about underlying cultural problems affecting healthcare nationwide. The emergency department at Riverside General Hospital transformed from routine medical space into crisis response, as Dr. Naomi Richardson's revelation of her true identity as Mayo Clinic Chief of Surgery created immediate institutional and clinical urgency, requiring comprehensive response. "I'm ordering STAT-CT angiography for aortic dissection protocol," Naomi announced with command authority that her weeks of deference had concealed. "Page cardiovascular surgery immediately. Prepare operating room for emergency aortic repair and get me cross-matched blood products. This patient has minutes, not hours." Her surgical precision and institutional authority were unmistakable, the transformation from deferential nurse to commanding chief surgeon happening instantaneously as patient survival required abandoning her cover. Dr. Hamilton stood paralyzed by shock and recognition that the nurse he'd been dismissing was actually surgeon, whose expertise exponentially exceeded his own diagnostic capabilities. "Dr. Richardson, I had no idea you were Mayo Clinic chief," Hamilton stammered, his medical confidence evaporating. "If I'd known your credentials, I would have—" Naomi interrupted with surgical focus. "Dr. Hamilton, my credentials are irrelevant. Mr. Johnson has aortic dissection that your anxiety diagnosis nearly killed him. We're correcting your error immediately. Every minute of delay increases his mortality risk." Her response made clear that revelation wasn't about asserting status, but about saving life that physician arrogance had endangered through systematic dismissal of accurate clinical observations. Head nurse Hayes mobilized emergency response with relief that Naomi's expertise was finally being properly utilized. STAT-CT for Mr. Johnson, OR prep for emergency cardiovascular surgery, and someone contact Mayo Clinic to verify Dr. Richardson's credentials. The verification would be formality. Naomi's command presence and clinical precision made her expertise obvious to anyone with medical knowledge. CT imaging confirmed Naomi's diagnosis within 15 minutes. Type A aortic dissection extending from ascending aorta into arch. Patient requires immediate surgical intervention. Without emergency repair, mortality approaches 100% within 48 hours. The radiologist's report validated everything Naomi had observed clinically, while condemning Hamilton's dismissive misdiagnosis that had wasted critical time. Cardiovascular surgeon on call arrived and immediately deferred to Naomi's expertise. "Dr. Richardson, I'm familiar with your work at Mayo Clinic. Would you lead this repair? Your outcomes in complex aortic cases are legendary." The professional. Respect contrasted sharply with Hamilton's dismissive treatment of her nursing observations, demonstrating how credentials, rather than actual expertise, determined whether medical opinions received serious consideration. "I'll lead the surgery," Naomi confirmed, while reviewing imaging and planning surgical approach. "Dr. Hamilton, you'll observe this case and write comprehensive analysis of how physician arrogance nearly killed this patient through systematic dismissal of accurate nursing assessment. Her directive transformed his error into teaching opportunity, while ensuring accountability beyond merely correcting immediate clinical mistake." Mrs. Grace Johnson grasped Naomi's hands with desperate gratitude. "You saved my husband's life. Thank you for not giving up when the doctor wouldn't listen." The family perspective provided crucial reminder that medical hierarchy affected real people whose survival depended on accurate diagnosis rather than physician ego protection. Mayo Clinic CEO Jonathan Pierce received emergency notification about Naomi's revelation. Dr. Richardson broke cover to save patient's life at Riverside General Hospital. She correctly diagnosed aortic dissection that attending physician missed, and she's currently performing emergency surgical repair. Pierce's immediate response was institutional support. Send Mayo Clinic surgical team to assist if needed and prepare comprehensive statement about Dr. Richardson's expertise and sabbatical. This incident will receive national attention, requiring careful institutional messaging. Hospital CEO Daniel Brooks recognized that having Mayo Clinic chief surgeon working anonymously as floor nurse created unprecedented situation with serious institutional implications. Dr. Richardson's presence here raises questions about our quality standards and physician culture. We need comprehensive review of how this happened. As Naomi prepared for emergency surgery, while her true identity spread through hospital, the transformation from dismissed nurse to commanding surgeon demonstrated how institutional hierarchy prevented recognition of expertise when it appeared in unexpected roles. The revelation would force Riverside General Hospital to confront systematic cultural problems while demonstrating to medical community nationwide how physician arrogance could be deadly when it prevented effective interdisciplinary communication and collaborative patient care. Riverside General Hospital's emergency department became center of medical revelation as Dr. Naomi Richardson's surgical expertise and Mayo Clinic credentials transformed understanding of the floor nurse who had spent 8 weeks observing systematic physician arrogance while maintaining anonymous cover. Naomi led emergency aortic repair with surgical precision that operating room staff immediately recognized as exceptional technique. She's performing complex cardiovascular surgery that most surgeons couldn't attempt. Her technical skill is absolutely world-class. The 6-hour operation saved Marcus Johnson's life through intervention that Naomi's instant recognition and persistent advocacy had made possible despite systematic physician dismissiveness. Following successful surgery, hospital administration convened emergency meeting where Naomi's identity revelation required institutional response to uncomfortable questions about quality, culture, and hierarchy. "I'm Dr. Naomi Richardson, Chief of Surgery at Mayo Clinic," she confirmed to assembled medical staff. "I took sabbatical to reconnect with bedside medicine by working as floor nurse. During 8 weeks here, I've witnessed systematic dismissal of nursing expertise, physician arrogance that compromises patient safety, and hierarchical culture that prevents effective interdisciplinary communication." Her testimony combined personal experience with institutional critique that her credibility as Mayo Clinic chief made impossible to dismiss. Mr. Johnson nearly died because Dr. Hamilton's ego prevented him from considering that nurses' clinical observations might be accurate, Naomi continued. But this isn't an isolated incident. I've watched physicians here routinely dismiss nursing assessments that prove correct. Systematic devaluation of nursing expertise is killing patients. The transformation from dismissed nurse to authoritative, surgeon exposing institutional failures created undeniable accountability that hierarchy alone couldn't prevent. Dr. Hamilton faced immediate consequences as medical staff recognized his catastrophic error. You dismissed Mayo Clinic Chief of Surgery's accurate diagnosis as anxiety, nearly killing patient through arrogance rather than clinical judgment. His humiliation was comprehensive. The physician who had confidently asserted diagnostic authority now revealed as less competent than nurse he'd patronized. State Medical Board launched immediate investigation. Dr. Hamilton's misdiagnosis and dismissal of accurate nursing assessment raise serious questions about his clinical competency and hospital's quality oversight. Head nurse Patricia Hayes provided testimony about systematic nursing dismissal. Dr. Richardson's experience as floor nurse validates what we've been reporting for years. Physician arrogance here routinely overrides accurate nursing observations, creating preventable patient harm. The nursing advocacy gained credibility through Naomi's unique perspective as physician who had experienced systematic disrespect that nurses face daily. Mayo Clinic issued public statement. Dr. Naomi Richardson took a proved sabbatical to reconnect with direct patient care. Her diagnostic excellence while working as floor nurse demonstrates both her extraordinary clinical skills and the valuable expertise that nursing staff provide to patient care. The institutional support from prestigious Mayo Clinic elevated the story to national medical news, examining hierarchy, expertise recognition, and interdisciplinary communication. Medical education organizations recognized case as teaching opportunity. Dr. Richardson's experience demonstrates that expertise exists independent of current role. Hierarchical assumptions about who can provide valuable clinical insights compromise patient safety. Harvard Medical School featured Naomi's case in curriculum. This demonstrates importance of recognizing expertise wherever it appears and dangers of dismissing clinical observations based on professional role rather than evidence quality. Marcus Johnson recovered fully and publicly thanked Naomi. Dr. Richardson saved my life by refusing to accept wrong diagnosis, even when doctor dismissed her concerns. She's hero who put patient safety above her cover story. Family gratitude provided emotional counterpoint to institutional analysis, reminding medical community that hierarchy and ego affected real lives. Dr. Solomon Mitchell, Naomi's mentor, reflected on the revelation. Naomi went to Riverside seeking to reconnect with bedside medicine. Instead, she exposed systematic cultural problems and demonstrated that true expertise transcends professional titles or current roles. National media coverage elevated story beyond medical community to broader public conversation. Mayo Clinic Chief of Surgery worked anonymously as floor nurse, saved patients' life when doctors missed diagnosis, exposed hospital hierarchy that endangers patients. As Naomi prepared to address hospital administration about systematic reforms, the power shift was complete. The mere nurse whose expertise had been dismissed was revealed as one of nation's top surgeons whose critique of institutional culture carried undeniable authority. The physician hierarchy that had enabled Hamilton's arrogance now faced comprehensive examination from expert whose unique experience provided unassailable evidence that systematic devaluation of nursing expertise wasn't just cultural problem, but measurable threat to patient safety, requiring immediate institutional reform. Within 2 weeks of Naomi Richardson's revelation, comprehensive institutional response transformed Riverside General Hospital from physician-dominated hierarchy into model for interdisciplinary collaboration while establishing national standards for recognizing and utilizing nursing clinical expertise. Dr. Lawrence Hamilton was suspended from clinical duties pending competency review. Dr. Hamilton's misdiagnosis and systematic dismissal of accurate nursing assessment demonstrate clinical judgment deficiencies requiring comprehensive evaluation before return to patient care. The suspension established precedent that physician arrogance compromising patient safety carried serious professional consequences beyond embarrassment. State Medical Board conducted investigation of Hamilton's diagnostic accuracy. Review of Dr. Hamilton's cases reveals pattern of diagnostic errors correlated with dismissal of nursing observations. His medical license is suspended pending remediation and supervised practice requirements. The licensing action demonstrated that systematic physician arrogance wasn't merely a cultural problem, but professional competency issue requiring regulatory intervention. Riverside General Hospital implemented mandatory interdisciplinary communication training. All physicians must complete training emphasizing nursing clinical expertise and collaborative decision-making. Hierarchical dismissal of nursing observations is grounds for disciplinary action. The institutional policy changes addressed cultural problems that Naomi's experience had exposed through first-hand documentation. Hospital CEO Daniel Brooks personally apologized to Naomi and nursing staff. Dr. Richardson's experience revealed systematic failures in our culture that endangered patients. We're implementing comprehensive reforms, ensuring nursing expertise receives appropriate recognition and clinical influence. The administrative accountability demonstrated institutional commitment to transformation rather than merely addressing individual case. National Council of State Boards of Nursing recognized Naomi's advocacy. Dr. Richardson's experience validates what nursing profession has documented. Systematic physician dismissiveness compromises patient safety. Her unique perspective as physician who experienced nursing devaluation provides powerful testimony for reform. Professional nursing organizations use the case to advocate for policy changes. Nurses provide continuous patient monitoring and clinical observations that brief physician encounters miss. Systematic devaluation of this expertise must end. Medical schools incorporated Naomi's case into curriculum addressing professional hierarchy. Future physicians must learn that expertise exists across healthcare roles and that dismissing nursing observations based on professional hierarchy rather than evidence quality endangers patients. Educational reform ensured that cultural problems would be addressed through training rather than merely punishing individuals who exemplified systematic issues. Mayo Clinic leadership welcomed Naomi's return with enhanced role. Dr. Richardson's sabbatical experience provided insights about healthcare culture that will inform our continued leadership. We're creating new position, combining her surgical expertise with broader institutional focus on interdisciplinary collaboration. The professional advancement demonstrated that her sabbatical and revelation had enhanced rather than damaged her career trajectory. Marcus Johnson made full recovery and became patient advocate. Dr. Richardson saved my life by refusing to accept misdiagnosis even when her expertise was dismissed. Patients deserve medical teams that value all clinical expertise regardless of professional titles. His advocacy provided patient voice in reform discussions often dominated by professional and institutional perspectives. Congressional hearings examined nursing expertise utilization in healthcare. Dr. Richardson's case demonstrates systematic underutilization of nursing clinical skills. Federal healthcare policy should incentivize collaborative models that recognize expertise across professional roles. Legislative attention elevated local hospital incident to national healthcare policy priority, requiring systematic rather than isolated response. Research funding supported studies of interdisciplinary communication. Dr. Richardson's experience suggests that hierarchy-based dismissal of nursing observations represents measurable patient safety threat, requiring evidence-based intervention. Academic research would provide data supporting reforms that Naomi's dramatic case had inspired through compelling narrative evidence. Professional conferences featured Naomi as keynote speaker. Working as floor nurse taught me that expertise developed as surgeon was systematically dismissed when it came from mere nurse. This hierarchical culture kills patients through preventable diagnostic errors. Her testimony to medical professionals carried authority that nursing advocates alone couldn't command, her physician credentials paradoxically enabling her to advocate for nursing expertise recognition. 1 year after the revelation, data showed measurable improvements at Riverside. Diagnostic accuracy improved 37%, nursing satisfaction increased significantly, and preventable complications decreased as collaborative culture replaced hierarchical physician dominance. Dr. Richardson's experience catalyzed cultural transformation that saves lives, quality metrics documented. The accountability process demonstrated that comprehensive response to medical hierarchy required professional discipline, institutional, policy reform, educational curriculum changes, legislative attention, research validation, and sustained advocacy, ensuring that nursing clinical expertise received recognition and influence proportional to its patient safety value. Over the following 36 months, transformation, catalyzed by Dr. Naomi Richardson's revelation, evolved from Riverside General specific reforms into national movement, addressing medical hierarchy and nursing expertise, devaluation that had compromised patient safety while institutional culture prevented adequate recognition of clinical skills, regardless of professional title. The Richardson Healthcare Collaboration Act established federal standards for interdisciplinary medical practice, mandatory nursing participation in diagnostic decision-making, protection against retaliation for clinical advocacy, enhanced scope of practice for experienced nurses, and Medicare reimbursement tied to demonstrated collaborative care models. Dr. Richardson's experience demonstrated that medical hierarchy endangers patients when physician arrogance prevents utilization of nursing clinical expertise. Congressional sponsors explained during legislative debate. National Institute of Nursing Research received increased funding for studies documenting nursing diagnostic contributions. Research validates that nurses' continuous patient observation identifies clinical changes that physicians' brief encounters miss. Systematic utilization of this expertise improves outcomes. Evidence-based analysis provided foundation for policies addressing documented rather than assumed nursing capabilities and contributions. Medical school curricula underwent comprehensive revision emphasizing collaborative practice. Future physicians must learn that expertise exists across healthcare professions. Hierarchical assumptions about diagnostic authority based on professional role rather than clinical evidence compromise patient safety. Educational reform addressed cultural attitudes at their source by teaching emerging physicians that interdisciplinary collaboration served patient outcomes better than hierarchical physician dominance. Nursing education programs enhanced diagnostic training. Dr. Richardson demonstrated that nursing expertise can match or exceed physician diagnostic accuracy. Enhanced education ensures nurses develop and maintain advanced clinical assessment skills. Professional development investments addressed both recognition of existing nursing expertise and systematic enhancement of nursing diagnostic capabilities. Hospital accreditation standards required interdisciplinary collaboration metrics. Facilities must demonstrate effective nursing participation in clinical decision-making, with specific measurements of nursing observation integration and physician responsiveness to nursing assessments. Structural accountability ensured that collaborative practice became institutional requirement rather than optional cultural preference. Mayo Clinic established Richardson Center for Interdisciplinary Medical Excellence. Dr. Richardson's experience inspired institutional focus on breaking down professional hierarchies that prevent optimal patient care. Center trains healthcare teams in collaborative practice models. The prestigious institution's embrace of reforms that their chief's experience had inspired provided influential model for other healthcare organizations nationwide. Naomi herself became national advocate while continuing surgical practice. Working as floor nurse taught me that expertise I'd developed as surgeon was invisible when delivered from mere nurse. Healthcare must recognize clinical skills, regardless of current professional role or title. Her unique perspective as physician, who experienced nursing devaluation, provided authority that nursing advocates alone struggled to command within physician-dominated medical culture. Technology platforms were developed supporting nursing clinical documentation. Digital systems ensure nursing observations receive equal prominence with physician notes in medical records, preventing systematic dismissal of nursing assessments. Infrastructure changes addressed practical barriers to nursing expertise, utilization beyond cultural attitude, reforms alone. Malpractice liability standards evolved to include failure to consider nursing observations. Physicians who dismiss accurate nursing assessments without adequate clinical justification face increased liability for resulting patient harm. Legal accountability created financial incentives for physician receptiveness to nursing expertise beyond professional or ethical obligations. Research demonstrated measurable improvements from collaborative practice. Hospitals implementing Richardson protocols showed 23% reduction in diagnostic errors, 18% decrease in preventable complications, and significantly improved patient satisfaction related to comprehensive care coordination. Data validation ensured that reforms could demonstrate concrete patient safety benefits rather than merely representing ideological preferences about professional collaboration. International healthcare systems adopted Richardson model nursing expertise recognition reforms demonstrate measurable patient safety improvements. Other nations implementing similar collaborative frameworks report comparable outcome enhancements. Global adoption elevated nursing expertise recognition from American cultural issue to international healthcare quality standard. 3 years after revelation, comprehensive transformation showed measurable impact. Nursing identified diagnostic insights were documented in 73% of complex cases. Physician dismissal of nursing observations decreased 89% under new protocols, and patient outcomes improved across multiple quality metrics. Numbers represent lives saved through systematic utilization of nursing clinical expertise, healthcare quality researchers documented. Professional recognition evolved as nursing expertise received acknowledgement. Advanced practice nurses gained prescriptive authority, diagnostic nursing roles expanded, and collaborative practice became healthcare standard rather than experimental model. The systematic reforms demonstrated that comprehensive cultural transformation required legislative mandate, educational revision, research validation, technological support, legal accountability, international adoption, and sustained advocacy, ensuring that clinical expertise received recognition based on demonstrated capabilities rather than professional titles or hierarchical assumptions. 4 years after Dr. Naomi Richardson's revelation at Riverside General Hospital, the physician-turned-nurse-turned-advocate stood before the National Healthcare Quality Summit, representing both personal transformation and systematic cultural change that had emerged from her unique experience bridging professional roles. 4 years ago, I was Mayo Clinic Chief of Surgery, working anonymously as floor nurse. Naomi addressed 5,000 healthcare professionals. I watched patients suffer and nearly die because physician hierarchy prevented recognition of nursing, clinical expertise that could have saved lives earlier. My revelation exposed systematic cultural problems requiring comprehensive transformation. Her testimony combined personal narrative with institutional critique that her credibility across both physician and nursing roles made uniquely authoritative. Mayo Clinic CEO Jonathan Pierce, whose institution had supported Naomi's sabbatical and subsequent advocacy, reflected on transformation. Dr. Richardson's experience revealed that healthcare excellence requires recognizing expertise wherever it exists, regardless of professional title. Mayo Clinic is better institution because we learned from her unique perspective. His institutional endorsement demonstrated that prestigious medical centers could embrace rather than resist reforms challenging traditional physician dominance. Statistical evidence showed measurable national impact. Diagnostic error rates had decreased 31% in hospitals implementing collaborative protocols. Nursing job satisfaction had improved significantly. Physician attitudes toward nursing expertise had shifted measurably, and patient safety indicators showed consistent improvements correlated with interdisciplinary collaboration. Numbers represent lives saved and complications prevented through systematic nursing expertise utilization, researchers documented. Riverside General Hospital had transformed from physician-dominated hierarchy into national model for collaborative practice. Our culture shift from dismissing to valuing nursing observations has improved every quality metric while creating work environment that attracts and retains excellent clinical staff. The institutional transformation demonstrated that addressing hierarchy served organizational interests beyond merely responding to external pressure or ethical obligations. Dr. Lawrence Hamilton had completed remediation and returned to limited clinical practice with permanent notation on medical license. Dr. Hamilton's case established precedent that physician arrogance compromising patient safety carries lasting professional consequences, requiring ongoing supervision and accountability. His professional humiliation served as cautionary example for physicians nationwide about dangers of dismissing nursing expertise through hierarchical assumptions rather than clinical evidence. Marcus Johnson, fully recovered from aortic dissection that Naomi's diagnostic expertise had identified, became powerful patient advocate. Dr. Richardson saved my life by refusing to accept wrong diagnosis even when her expertise was dismissed. Every patient deserves medical teams that value all clinical skills, regardless of who provides them. His gratitude and advocacy provided patient voice, emphasizing that medical hierarchy affected real lives beyond abstract professional debates. Head nurse Patricia Hayes had been promoted to chief nursing officer at Riverside with expanded authority. Dr. Richardson's experience validated what nurses have known. Our clinical observations are essential to patient safety. New collaborative culture empowers nursing expertise appropriately. Her professional advancement demonstrated that cultural transformation created opportunities for nursing leadership previously prevented by physician-dominated hierarchies. Medical schools across the nation incorporated Richardson case study into curriculum. Future physicians learn that dismissing clinical observations based on professional role rather than evidence quality endangers patients. Dr. Richardson's experience provides powerful teaching example. Educational integration ensured emerging physicians understood collaborative practice as professional standard rather than optional courtesy. Nursing schools enhanced diagnostic training using Naomi's case as inspiration. Dr. Richardson demonstrated nursing expertise can equal physician diagnostic accuracy when properly developed and utilized. Enhanced education ensures nurses achieve their full clinical potential. Professional development addressed both recognition of existing expertise and systematic cultivation of nursing diagnostic capabilities. Harvard Medical School, where Naomi trained, featured her as distinguished alumna. Dr. Richardson's journey from floor nurse back to surgical chief while transforming healthcare culture represents medical leadership at its finest, using personal experience to catalyze institutional reforms benefiting all patients. Academic recognition from prestigious institution elevated nursing expertise, advocacy to highest levels of medical professional culture. Research continued documenting collaborative practice benefits. Long-term studies show sustained improvements in diagnostic accuracy, patient safety, and clinical outcomes when nursing expertise receives systematic recognition and utilization in medical decision-making. Evidence-based ensured reforms persisted beyond initial enthusiasm by demonstrating measurable patient care benefits. Dr. Solomon Mitchell, Naomi's mentor, reflected on her transformation. Naomi sought sabbatical to reconnect with bedside medicine. Instead, she exposed systematic cultural problems and catalyzed national healthcare reforms. Her impact extends far beyond individual surgical excellence. Mentorship perspective validated that personal growth often emerged from unexpected experiences that challenged rather than confirmed existing assumptions. Mayo Clinic Richardson Center for Interdisciplinary Excellence became national training hub. Healthcare professionals from across the country learned collaborative practice models based on Dr. Richardson's experience and research validating nursing expertise integration. Institutional legacy ensured Naomi's revelation inspired ongoing education rather than remaining historical incident without sustained practical impact. International healthcare delegations studied American nursing expertise reforms. Richardson model demonstrates how cultural transformation addressing professional hierarchy improves patient safety outcomes. Other nations implementing similar approaches report comparable benefits. Global adoption elevated reforms from American cultural change to international healthcare quality standard. As Naomi concluded her keynote address, she emphasized continuing work. We've made progress recognizing nursing clinical expertise, but hierarchical assumptions persist. True transformation requires sustained commitment, ensuring every healthcare professional's skills serve patients regardless of professional titles or traditional role boundaries. Her message acknowledged both achievements and ongoing challenges, maintaining momentum for continued cultural evolution. Naomi's closing words reflected wisdom gained from unique journey. I became surgeon to save lives through technical skill. Working as nurse taught me that saving lives also requires recognizing and utilizing expertise wherever it exists. Healthcare excellence demands collaboration, humility, and commitment to patient safety above professional ego. The standing ovation acknowledged both her courage and the systematic transformation her revelation had catalyzed. 4 years after revealing her identity to save Marcus Johnson's life, Dr. Naomi Richardson had transformed from burned-out surgeon seeking reconnection with patient care into national healthcare reform leader whose unique experience bridging professional roles provided unassailable evidence that medical hierarchy endangered patients. Her legacy would be measured not in surgical innovations alone, but in countless lives saved, because healthcare culture shifted from dismissing to valuing nursing expertise, from hierarchical physician dominance to collaborative interdisciplinary practice, and from assuming diagnostic authority based on professional titles to recognizing clinical skills wherever they existed. The Mayo Clinic chief of surgery, who worked anonymously as floor nurse, and the physician-dominated culture that dismissed her expertise, had together transformed American healthcare, proving that systematic reform could emerge from individual revelation when unique perspective, institutional authority, and sustained advocacy converged to demand recognition that clinical excellence transcended professional roles and that patient safety required utilizing every team member's expertise, regardless of hierarchical assumptions about who could contribute valuable diagnostic insights. That journey, from burned-out surgeon to anonymous nurse to revealed expert to national reform leader, represented the kind of transformation that made both individual institutions and entire healthcare system more collaborative, more effective, and more faithful to principles requiring that patient care benefit from all available expertise rather than being limited by professional hierarchies that served ego more than outcomes. Up next, you've got two more standout stories right on your screen. If this one hit the mark, you won't want to pass these up. Just click and check them out. And don't forget to subscribe and turn on the notification bell so you don't miss any upload from us.